Good afternoon. Welcome to our 16th Facebook Live with the Medical Association of the State of Alabama. My name is Aruna Arora, the current president, and I'm joined here today with Dr. Scott Harris, our state health officer, Dr. Mike Saag, our extraordinary ID expert from UAB here, and Dr. David Thrasher, our pulmonary ICU physician expert from Montgomery. So welcome everybody. We are here to give an update on Omicron. Dr. Harris, if you want to start us off.
Sure, I would be glad to. Thanks very much for having me, and we appreciate everybody who's joining us today. It's great to connect with you, and we always enjoy being able to reach out through Facebook Live. I'll just briefly give you a sense of what our numbers are doing right now. I think everyone is probably well aware that we're seeing case numbers unlike any we have ever seen before. Daily case numbers have gone up at a rate that we just had no idea could even be possible. In the last week, we're averaging more than 10,000 cases per day. Until the last week of December, we had only seen 5,000 cases on a single day, just a couple of times in the entire pandemic. And yet now we're averaging more than 10,000 cases. Yesterday's numbers we're still trying to verify, but look like are going to be over 14,000 cases in a single day reported to us, approaching 15,000. It's just mind-boggling, and we don't know how much longer it's going to go on. I'm sure you may have seen that in other countries where Omicron arrived first, and even in the northeastern United States right now, it's possible that the case numbers are peaking and maybe cresting, and perhaps we might see some improvement in 2 or 3 weeks, like those other places have seen. The truth is we just don't know, because one thing we know about COVID is we just don't know, and it's really hard to predict the future. There is evidence that Omicron is not as severe as what we saw with Delta, thankfully, if there's one silver lining, although it's certainly no walk in the park either. There's been a particular study from the UK that showed that Omicron caused deaths at about half the rate of Delta. If true, that's really terrific. Although that's still a lot of death, unfortunately. During Delta, Alabama saw about 2% of all people infected die with that disease, so about 2 out of 100. If the numbers we're seeing, the numbers we have heard about Omicron are correct, maybe that mortality rate is going to be more like 1% instead, 1 out of 100. And certainly that's better than Delta, but that's still 10 times the rate of death we see with influenza. And at some point, when you have case numbers like this, just the sheer number of people getting infected, 1% of a really big number is a really big number. And so we get a lot of demand for healthcare services. Our hospitals are really put under stress, even though you have a disease that we may think on average might be a little milder than the one we've seen before. So we still are in a really difficult situation. Hospitals today have reported to us just under 2,100 inpatients total around the state. Here in central Alabama, where I'm located, as Dr. Thrasher knows well, we have negative ICU capacity overall. There are some ICU beds available in some parts of the state, but not much down here in the river region around Montgomery, unfortunately. It's probably true that there are less Omicron patients ending up in the ICU. A lot has been made of the fact that many patients are being admitted to the hospital for other reasons and then turn out to have Omicron. That's undoubtedly true. This is a really highly transmissible variant. But I would say, while that's really good for the patient, from the hospital, it doesn't make that much difference. They still have a patient known to be infected with COVID. They have to isolate that patient. They have to use PPE on that patient. They have their own staff being put at risk for getting infected or exposed. They have other patients in the hospital that can still be infected and exposed. Hospitals need to be open to take care of all the things hospitals do. And so when you have thousands of cases going on in your community, that risk is transferred right into the most vulnerable group of people, that is the people who are hospitalized in your community. So while we're glad there are less people being admitted for COVID, there are still a lot of people in the hospital with COVID, which turns out to be the same thing from the hospital standpoint. We really wish we were doing a better job with vaccinations. We have talked about this now till we're blue in the face for over a year now. We aren't seeing a lot of new people show up to get vaccinations, but we still have a lot of room we can improve with people getting boosted. We know people who've who have completed their initial series and who need to be boosted. These aren't people who are opposed to being vaccinated, apparently. And so we still are trying to get the message out to them that as soon as they're eligible, they need to get boosted. That's really important when we're talking about Omicron, where being boosted really makes a difference in how you do if you are exposed or if you subsequently get infected. So finally, I'll just say that we're working really hard on testing. We know there's a lot of testing shortages right now. There's not necessarily a big change in the amount of tests that have been made available around the country, but there's a huge increase in demand for testing. So right now we're having, as I mentioned, 10 or 12 or 14,000 positive cases a day. These are all people who, for some reason, decided they needed to go get tested for COVID, and that's happening every single day. And so we're having 25 to 30,000 cases or tests being done every day. And those are just the ones that we know about, the over-the-counter tests that people buy and take home or order off the internet or buy at the drugstore. We don't actually even know how many of those there are, but there are many, many thousands, I'm sure, being used as well. So we have worked with a number of vendors who are helping us to set up testing locations. We still do have testing available in every county health department every single day, maybe not all day long every day, but at least every day in every single county health department. We are working with other ways to bring tests in as well that we'll try to give you more information about. But we expect we've got at least a few more weeks of this before hopefully we begin to see some improvement. So Dr. Arora, that's really kind of all I had as for introductory remarks. And thanks again for letting me join you.
Thank you, Dr. Harris. Dr. Saag, if we can go to you for an update on Omicron and what you're seeing in the hospital and the clinics.
Sure, thanks. Let me add, sort of pick up where Dr. Harris left off. The numbers that he's giving us, I think you can almost go up by a third in terms of people who are testing at home, positive tests, and just aren't getting reported. So we're in the middle of an incredible flood of cases right now. At UAB Hospital 2 days ago, we had almost about 200 people in the hospital. That's a little lower than the high water mark that we had before, but it's still significant. About 30 to 40% of those individuals are what we call incidental, which is different than before, meaning they came in with a car accident or a burn or a heart attack, and they got swabbed on the way in to the hospital, and they were incidentally found to be infected. Most of those folks are not terribly ill with their COVID. On the other hand, we've got 48 people in the ICU right now. That's below our high water mark of in the 60s or 70s with Delta. And again, the vast majority of those folks are unvaccinated. And then we have about 30 people on the ventilator. And again, the majority of those individuals are unvaccinated. And so the adage that we've been screaming from the rooftop since the beginning, especially when vaccines became available, is absolutely still true. The people who get into trouble right now with COVID, as a rule, are those who have not made the decision to get vaccinated. And by the time they come to the hospital, it's too late. You can't get vaccinated. Regarding shifting a little bit to treatments, and I'll turn it to Dr. Thrasher to talk about how this is playing out on the ground at his hospital. But we used to have the two major products for monoclonal antibody that was the Regeneron and the Lilly products, which unfortunately have little to no activity against Omicron. And now that 98+% of our cases in the state are Omicron, that protection is gone. So what we're left with is a product from GSK called sotrovimab, and sotrovimab is active against Omicron. The problem is that since Lilly and Regeneron were dominating what was being used, they didn't scale up production for the sotrovimab back in the day. And so now they're being asked to, and you can't just flick a switch and create production. You have to gear up, and they are doing that, but it's not going to be in time to really help us. And Dr. Harris can go into the gory details of how we get that, but it's basically distributed through a national distribution network to all the states. It goes through the health department to our hospitals based on prior utilization. It just didn't enough coming in. The other two things that are new that are important are the two drugs from Pfizer and from Merck. Right now, Walmart has just gotten a brand new supply of the Merck product called molnupiravir. Now, that is a drug that's a nucleoside inhibitor of transcription, and it works decently against Omicron or against any COVID virus, but it's only about 30%, maybe 35% effective. Paxlovid, which is a Pfizer drug, it's a protease inhibitor. It works almost 85 to 90% in protecting against hospitalization and death when you use it early. So the key things to remember here are: one, diagnose patients as early as you can. Two, use the algorithms that we've used for monoclonal antibody to target the use of these products for people that are at higher risk for progression to hospitalization and death. And that includes those who are immunocompromised and those who haven't been vaccinated and are obese or have underlying health conditions like diabetes, high blood pressure, lung disease, kidney failure, that type of thing. But unfortunately, the Paxlovid is also not in great supply right now. So Walmart had a fair amount of that, or a little bit of that, last week. That ran out quickly. Molnupiravir is now available in Walmart, at least for the time being. The dose of molnupiravir is 4 tablets twice a day for 5 days. Start as soon as you can. Think Tamiflu for flu. You want to get it as fast as you can because you're trying to shut down viral replication, which is rampant in the first 3 to 4 days of infection. And then the body takes over in clearing it. If you can help it out, give air support for the infantry, that really works well. For Paxlovid, when it becomes available, I think it's a superior product. It's a protease inhibitor, and those of you familiar with HIV, this is old hat. It requires boosting with an agent called ritonavir, which is a very potent inhibitor of the isoenzyme CYP3A4. Now, go back to your pharmacology class in school, and you can remember that that's a liver enzyme that's responsible for metabolizing drugs. Very potent inhibitor, so it works well for getting the Paxlovid protease inhibitor concentrations high, but it interferes with the metabolism of a lot of other drugs that people are on. So you've got to check for drug interactions as you prescribe it. Fortunately, and I'll put it in the chat, or I will try to get this out to everybody, there's a wonderful website out of the University of Liverpool. So if you just Google University of Liverpool COVID drug interactions, it'll take you, you could choose Paxlovid and then any medicine they're on, and it'll tell you if it's safe to use, and if it is does require dose adjustment, it'll tell you what to do. And it will also have this big red box that says, don't use this while you're using these other medicines. So that's a long-winded report, but there's a lot that's happened since I was with you last, and I think I'll turn it over to Dr. Thrasher to fill in the gaps of what I missed.
Thank you,
You don't
Dr.
ever miss very much, Mike.
So Dr. Thrasher, if you want to give us a little bit about your practical experience right now in the ICUs and clinic.
Sure, and I agree with Dr. Harris and Dr. Saag. Omicron is really overwhelming right now. I looked at some numbers this morning. Compared to 1 year ago today, there are 250% more cases of COVID today. The number of people dying today versus a year ago is up 39%. Well, 39% is a big number, but like they both said, the Omicron number of patients who have that is so big, but still a small percentage, 1% even less, that get really sick is a big number. Now, our ICUs are completely full here. Okay, we're in pretty bad shape. Big part of that is that we don't have staff. The staff are out sick. The nurses are sick. Doctors are sick. Respiratory therapists are sick. So we're really limited by staff. That's not unique to us. That's all of the United States. 20% of healthcare providers, doctors, nurses, et cetera, are no longer on the job for various reasons. Dead of COVID, long COVID, post-traumatic syndrome, whatever, are just tired. So we have a lack of personnel. And so those are the numbers. Now, Omicron is clearly not nearly as tough on the majority of patients. And I've been getting probably as many 50 new patients a day, call, text, or whatever, reach out. Most of these I pretty much handle with, I'm still using the inhaled budesonide, the inhaled steroid and a nebulizer, which really turns the symptoms around in about 48 hours on most of these people. Now, I got 6 doses of Sortimab today at Jackson Hospital, 6 doses at Baptist. 12 doses out of 400 people that I've seen over the last week that could use it. What I'm doing is pretty much restricting that to the sickest of the sick, or the most vulnerable. Pregnant women are very high on my list. Okay, I have a low threshold for not treating them for various reasons. Cancer patients on chemotherapy, high risk. Rheumatoid patients on immunosuppressants, or people inflammatory bowel disease who did not probably get a good immune response from their vaccines, they're high priority. But having said that, we just got a limited dose. The Paxlovid is supposed to hit the Walmarts tonight. They ship it every other week, just like Dr. Saag and Dr. Harris said. Pfizer is making it as fast as they can, but they really weren't given enough notice. So whenever we get enough, I think the Paxlovid, I think we'll turn this into an endemic rather than pandemic, like Dr. Saag has said in the past. And that's really where we are. Our hospitals are overwhelmed. Our ER is overwhelmed, and the morale and the stress on our staff is really unbearable. And that's where the public comes in. Please get your booster if you're not boosted. And I no longer ask anybody if they're vaccinated. To me, that doesn't get vaccinated is if you had a booster. 2 shots, well, that's a good start, but you need a booster. That's the only thing that's going to keep you from getting real sick. Having said that, maybe 40% of people in the hospital, like Dr. said, are vaccinated, but for other reasons. But we're not seeing the people get nearly as sick as we did with Delta. If Delta had been as contagious as Omicron, and we did not have any bullets in our gun like we have now, there would have been bodies on the street with Delta.
Yeah, which is a scary thought. I think one of the important points here, I know a lot of critics to vaccines are showing, some of the messaging that's come out about Israel and a 4th booster as kind of a deterrent or a reason not to get your first vaccine. But Dr. Saag, do you want to explain adaptive immunity and how important it is to really understand that each new variant, still your body is not like 2020 when we did not have a vaccine?
Yeah, let's dig into a little bit of the normal immune response. There's really 2 phases, just to keep it straightforward. There's innate immunity, which occurs anytime our body is exposed to something new it's not seen before. And that innate immune response is mostly interferon. And in the case of a viral infection like COVID, that interferon, as soon as it starts to recognize that the virus is there, it spikes up and also causes symptoms. It makes you feel bad. And so, like most infections, feeling bad from an infection is almost always the immune system cytokines that are generating that bad feeling. Then as that clears the virus, the second phase of immunity is the adaptive immune response. So think T cells, B cells, and antibody. And those are very specific, targeted responses to that pathogen. In the case of COVID, we do see some degree of cross-reactivity for the antibodies that can bleed from one variant to another. It's just not as efficient as it would be for the original variant. So if somebody got infected last year with, let's say, the Alpha variant, then they got exposed to Delta over the summer, they likely would develop symptoms from a Delta exposure because it just wouldn't clear it as efficiently. The vaccines do a great job of creating a broader antibody response in general than the original infection. And the best thing, not that you want to have the infection, but the best immunity is someone like me who had the infection originally back for me in March of 2020, then got vaccinated, then got boosted. And my immunity is pretty robust right now. And it's mostly, as you said, Dr. Arora, it's mostly adaptive immunity that's ready to go. Right now, I think one of our most vulnerable populations are those children under the age of 5. We didn't see as much infection with Delta or Alpha variants, but in that age grade, but we seem to be seeing a lot more with Omicron. Maybe it's just the numbers. Maybe it's just so much more infection. And if, as Dr. Harris was saying, if you take 1% of 1,000 people, right, that's 10. But if you take 1% of 100,000 people, that's a whole lot more. It's 1,000. So when you have that many kids getting sick, the Children's Hospital of Alabama is getting swamped right now, and they're struggling. And I had a granddaughter visiting over here, and she got sick while she was here. Fortunately, none of the adults got sick around her. She's 2.5. Our immunity worked from the vaccines. Every one of us was vaccinated and boosted. We probably got transiently infected and cleared it, never developed symptoms. But for her, it was a pretty bad infection. She didn't have to go to the hospital, but I saw it firsthand. And that's what I think a lot of parents are seeing now. It makes me a little bit concerned about, I want students to go back to class. I want them to go to school. But for goodness sake, let's make it safe for them, or as safe as we can. If your child is eligible for vaccination, get them vaccinated, please. And if they aren't eligible and they're able to wear a mask, that's the best thing we can do to help them, by far and away. That's what we can do to help each other and help our own kids.
Mike, let me ask you a question here, if I could. You've had COVID, and you've been boosted as well. I had a patient came in earlier this week, who was taking care of, quite ill, very sick, had not been vaccinated. His doctor advised him to go out to a COVID party, get it so that be protective. He said it's not too bad and everybody needs to get it. How would you comment on that?
Yeah, I remember that from when I was growing up with chickenpox back in the 50s and 60s, and dating myself, but mom would have a child with chickenpox and they'd have a party at the house so that all the other kids in the neighborhood, and that worked. Why? Because when you get chickenpox, your immunity is pretty robust to prevent a second case. Now, later in life, you can get shingles, but that's another story. But for COVID, as we've learned and as you've seen and as you've experienced, we know that immunity, and this maybe got to your earlier question, Dr. Arora, about adaptive immunity and things. We know that immunity only lasts about 6 months at most, 5 to 6 months. And so that's what happens when things kind of wear off and you can't get reinfected. The question about herd immunity that everyone's hanging their hat on, it ain't going to happen. It's just not going to happen with this, not because we won't get enough people infected. I suspect we might over time, but the immunity is short-lived, and relatively speaking, it's not lifelong. And so we're not going to get it. The way we can create a medical herd immunity is by getting vaccinated and being boosted appropriately over time. How often? I don't know. We'll find out as we experience things. But what we know for a fact right now is that those people who were vaccinated and boosted might get a little bit sick, get a common cold equivalent, have a pretty wicked sore throat. I've seen a lot of that. But it clears in 3 to 4 days, and they don't go to the hospital. The people in the ICUs, the people on ventilators, the people on ECMO right now are those who are unvaccinated as a rule. And I don't know how much empiric evidence. I'll finish with this comment. We're weighing out, it's not vaccine, yes, no. We're weighing out what's the risk of the vaccine versus what's the risk of getting COVID. I just told you the risk of getting COVID. For all the people who are still hesitant about a vaccine, look around at your neighbors who have been vaccinated and ask yourself, how many of them have gone to the hospital from a side effect of the vaccine? And then ask yourself the question, among your neighbors, how many who weren't vaccinated when they got infected went to the hospital? There's your answer about safety. These vaccines are remarkably safe and remarkably effective. I shudder to think what our summer would have been look like, and even right now, had this vaccine failed a year ago. We would be and I think as Dr. Thrasher said, we'd be seeing bodies stacking up. And we haven't because of the vaccine. And we'd all be better off if we bank on herd immunity through vaccination over time. That'll get us out of this nonsense COVID isn't going to go away. It's going to be with us for a long time. Why not use the tools we've been given to keep it under control?
I agree with that, Mike. And one thing, the headlines always talk about the hospitalizations, how many cases. What they don't do is talk about how many people have long COVID. Just about all the patients I'm seeing in the office now, I let my partner see the COPD, the lung cancer, the other things. I'm just seeing long COVID. The numbers have been as high as 20% of all cases may have some degree of long COVID. That's what you don't want. And some of these have been relatively asymptomatic early on. About a third of these have developed what I call mental fog, neurological. A significant number have chronic lung problems, and some have cardiac problems. So just because you survived COVID, and went to a COVID party, you don't want long COVID. I promise you. Most of the people lose their taste and smell, get it back in 6 months. But I have several people, and we tried everything, that still cannot taste and smell. And a lot of them, and some professionals, that are probably going to have to go on disability because they cannot concentrate. So long COVID is something you don't want. Get vaccinated.
I think that's an excellent point in terms of what you were talking about, Dr. Saag, with the young population right now. You've got Omicron that's raging in terms of infectiousness or infectivity, and and then the possibility of long COVID. We don't really know the details on this, but certainly the under 5 are that much more able to get infected if their siblings are going to school and coming home picking up a virus. So we've wanted to keep schools open. We still want to keep schools open. I'm sad to say that our own school just turned virtual today because the infections are higher. And so, part of this is doing what we need to do, get vaccinated so we can move on. And I think that reality is important to understand. I guess last year there was some criticism about how the economy and how things were moving forward with this pandemic, but it's truly important to understand that the virus is here. We cannot make this virus go away. We can do what we can do, which is get vaccinated, and Dr. Saag, you made an excellent plea for how this vaccine has been safe. Look at your neighbors, look at people who've gotten this vaccine, look at who is going to the hospital that is it the unvaccinated, is it the vaccinated? I think those are really important points to remember. Dr. Harris or Dr. Saag, can one of you touch on boosters for pediatric population? I know that was something that did come up after we last had one of these sessions.
Sure, I'll do my best. If I could just tack on to what was just said by each of you, we actually have an opportunity for a really interesting kind of observational experiment right now, which is when Omicron hit Alabama, we had about 50% of our state vaccinated. It's about 50-50. Okay, so the people who are vaccinated actually are disproportionately older and have chronic health problems, because those are the people, thankfully, who have heard our message. But there's half the people out there are vaccinated, half are not, and the people in our hospitals now are overwhelmingly unvaccinated people. Certainly, at least 2/3 of them are unvaccinated people. The people in our ICUs on ventilators are predominantly overwhelmingly unvaccinated people. And even though we haven't had Omicron around long enough to know for certain about deaths, we know for the last almost 2 years, virtually all our deaths, or certainly since the vaccine's been available in the last year, our deaths are among unvaccinated people. So let's, as you say, let's see what happens. It seems to be the people who are unvaccinated who are bearing the burden of this for the most part.
That's a great point, Dr. Harris. I think one of the hardest realities to understand for our state is, some of the comorbidities that are rampant in our state really are not going to play well if you remain unvaccinated. Obesity, there are some things that even if you are young and you choose not to get unvaccinated, it doesn't mean you are going to be without the risks of a 65-year-old, so age is certainly a risk factor, but there are other risk factors that some of us who are younger share. So, I think this is just a really good opportunity to revisit your doctor, talk to your doctor. It's never too late to have this discussion again, and just really, really kind of consider something that you may not have considered before.
And real quick, I think we failed to answer your question completely, but the boosting for kids is like age 12 and over If they've had their original series, now's a good time to get them boosted. We aren't quite at the point for boosting the 5 to 11-year-olds as far as I know. But we're hopeful that maybe by the end of this month, beginning of February, the 2 to 5-year-old data will start coming in, and we may be able to release vaccinations for that group coming up.
Yeah, I'm sorry, I forgot to answer that part of the question, but and it's important to point out now that those who've received Pfizer and Moderna now, the interval to get boosted is 5 months after completing your first 2 shots. It's not 6 months, but 5 months for both of those now. Remember, Moderna is available for people who are 18 and up. So in terms of the pediatric population, all those kids would have gotten Pfizer. That's the one that's approved for those age groups. And as Dr. Saag said, age 12 and up are eligible for a booster beginning at 5 months after completing their first 2 shots.
I did see something about, was it in New York, where they're requiring boosters for the adolescents who are playing sports. So I guess that just brings up a question here. In our area with schools and extracurriculars and sports, I know non-pharmaceutical intervention is not something anybody really wants to discuss, but can we please go over some of the common public health messaging? You know, if you are unvaccinated and Omicron is certainly here and spreading, can we talk about the masking and reiterate that message that should never really go away if you're at risk?
Sure. Please let me go first. We have not changed our guidance, in 2 years on most of this, or just maybe very mild ways. It may have changed just a little bit, but we continue to recommend universal masking for all K through 12 schools, for kids, for adults, for employees, for visitors, for parents, for anyone who's in that building. That is the current recommendation. We continue to do that. It's up to individual boards of education in the state of Alabama to do that. They have the authority to make those decisions, but our guidance has not changed on that at all. Similarly, mask for anyone in indoor public spaces makes sense. And I would say that, applies to people who are vaccinated as well. I think we all agree that with the level of infectivity we see with Omicron, doing everything you can possibly do to prevent getting infected makes sense. And for people who are particularly vulnerable because they're older or because they have chronic health problems, I would just say I wouldn't get together with groups of people who, if you don't know their vaccination status, if you're not able to space, if you're going to be indoors for long periods, that's not a good environment to be in. And I think that really applies to everybody, not just high risk people. But in particular, Alabama has a big burden of chronic disease already. We have a lot of vulnerable people. And right now, the next 2 or 3 or 4 weeks is just the time to avoid those gatherings if you can possibly do that at all.
I'd like to highlight that and just say that I feel like pretty strongly that this epidemic is cresting. It's peaking right now in Alabama. I think perhaps by the end of the month, we will see this downturn coming. Time will tell. But what I'm trying to point out is that if we can just hunker down for the next couple of weeks and just be safer. And the reason I'm saying that is that one thing that we can look at, not just the daily caseload, but there's another way of analyzing this in terms of cases per 100,000. And we'd like that number below 10 and preferably below 5. And back in June of 21, we were right about there at 3 cases per 100,000. And we started coming down 1st of December. The highest we've ever seen is this week. And we're seeing around 200 plus cases per 100,000. What does that mean? It means if you get 10 people in a room together, the probability that one of the 10 people have Omicron at the moment you're getting with them is 70%, just 10 people. And if you've got 25 people, you're well into the 90% likelihood that 1 out of the 25. And that's why we say avoid large crowds now. That's why we say just be judicious for the next 2 to 3 weeks, and then we'll get out of it. It's just a couple more weeks of just hunkering down and we can get through this.
I think that's a great description of the risk, how you just broke it down, and also just the time period. We're not saying forever. This is just a surge at the current time. So A couple of questions that have come in. One is regarding the monoclonal shipment, and the other is antivirals. And just in terms of, have we received these shipments? Are they being distributed? Quantities, that kind of thing. And
Sure.
I think
I'll
you did
be
touch
glad
on
to
that.
address that. We have been getting the monoclonals now for the past 3 weeks or 4 weeks, perhaps. We are distributing those geographically around the state so that they're available in all regions. It is, like when you ration any scarce resource, there's just no way to make everyone happy, and maybe no way to make anyone happy about that. But we move those a little around, just a little bit from place to place each week. We follow utilization, and I can tell you virtually nobody has any left over. I mean, it's all getting used each week when we get it. This week we have a total of about 420 doses, or this past week, 420 doses. It comes in a minimum package size of about 6. And so you can do the math and just see there aren't going to be very many places, 70 something locations or so, that are going to be able to get any product whatsoever. The shipment that's coming out this week is a little bit larger. We're going to be able to get it to about 100 locations. Each one's going to get about 6 doses. Unfortunately, we just don't have any more. And every hospital and provider thinks their patients are deserving, and they're all exactly right. Everybody's deserving. But unfortunately, there's just not enough to go around. In terms of the oral medications, the oral antivirals, those are available now. As Dr. Saag pointed out earlier, the Paxlovid disappears really, really quickly. We only see those shipments every couple of weeks. At the moment, we are using our federal retail pharmacy partner, Walmart, to distribute those, and that they're located in a lot of rural communities. They have a statewide presence, and they have agreed with us that they can move product if they're not, dispensing it at some location, so we can get it to those locations that need it the most. We are this week actually adding some independent pharmacies as well. As soon as we have enough product, there are about 20 independent drugstores in the state that are getting molnupiravir. We don't have any additional ones who are able to get Paxlovid at the moment because we just don't have any product.
Okay. And then a question about testing. As pharmacy partners are not having testing, they're coming into shortages. Are we going to see any sort of plan for mass testing from the state?
So yes, as we mentioned a little bit earlier, we are talking to private companies that are offering some pop-up testing now. We're particularly looking at trying to put that in the southeastern and southwestern parts of our state, because those communities, even though there's shortages everywhere, those in particular don't have a lot of other places that they can go. So we are hopefully going to have that up very soon. We in public health are running out of testing as well. We normally buy tests from a couple of different channels, and we've been told that there are none available for us to purchase right now, in fact. So we're running low in many of our own facilities. Okay.
And then what percentage of the COVID hospitalizations happen to be incidental?
In UAB, that we're tracking that. Yeah, we're tracking that pretty carefully. It's 30 to 40%, which is much different than what we've ever seen before. So that's something. So out of the roughly 200 people, there could be 70 or 80 who are in the hospital with COVID. We got to still take the precautions and all that. They've got an active infection. Let me ask one other question we haven't talked about yet that's kind of new information. There's a study called Pine Tree that tried outpatient remdesivir. Remember, remdesivir is a drug that was approved in May of 2020. And everyone said it's being given too late because of what I just said. Remember, I talked about that viral spike by day 0 to 3, and then the innate immunity brings it down, that we weren't giving remdesivir until days 8, 9, 10, which is really too late. So a study that was done looked at 3 days of IV dosing, a double dose on day 1, 200 milligrams IV, and then bring them back on day 2 and 3 with 100 milligrams. And this drug is pretty readily available. And so for those who are really high risk, we can't get the sotrovimab right now. That's an option. If you've got somebody you're worried about, bring them to an outpatient infusion center, give them 200 milligrams IV on day one, bring them back the next day, 100 milligrams, bring them back the next day, 100 milligrams, reduces hospitalization by over 80%. So that's another option that we haven't been employing, but I think we're going to need to. It's inconvenient. You don't have to watch them as long after the infusion like you do with sotrovimab or the other monoclonals. And it is inconvenient for the patient, but in the hospital setting, but it really does work. It's another option.
That is really, really useful that you mentioned that, because I know everybody's getting a little nervous as we talk about the lack of availability of sotrovimab, Paxlovid. And so to know that there is something out there, an ample supply for providers to help their patients with. So thank you for that. And so now I think we're at a point where we probably should wrap up. We've had a great interactive session. Dr. Harris, anything for closing?
No, just if I can go back to my normal commercial, I do. We have vaccinations available for free, 5 days a week, every county health department, multiple other locations in every county in the state. In most cases, no appointments needed. Any person age 5 and up, please get vaccinated as soon as possible if you haven't done so already. If you have been vaccinated, please get boosted as soon as you're eligible, which is 5 months or more after you completed your primary series. Wonderful.
Dr. Saag?
No, I agree. This has been a great interactive session, and thanks for the opportunity. Just we've said all the things. It's just it's a tough time right now, but we're going to get through it, and it'll hopefully be soon.
That's wonderful. Dr. Thrasher?
I agree 100%. Everybody hang in there. Don't go to social islands that you don't have to the next few weeks. Like Mike said, this thing's going to be over, I think, by the end of February, early March. So hang in there. It's not forever. Get boosted. If not for you, but for the nurse next door.
Absolutely. What goes up has to come down. Please, please be vigilant right now. And if you have not considered getting vaccinated up until now, please, it's never too late. Thank you for tuning in. Thank you all for participating.